Thank you. Wow. Can I ask you to take your seats? And what an amazing, we've had 3 days. Some of us, actually, I say 3 days. We have had a week. Our first meeting started on Sunday. And I think the tribute to the active participation we get at this conference is amazing that so many of you are still here and not escaped to enjoy Lisbon. And it's a really beautiful city. Actually, someone did suggest that we'd actually arranged a little bit of rain. I talked to Manuel, just a little bit of rain. We don't get much in Lisbon, to try and keep people here this afternoon. But we didn't, but I'm just really so impressed that so many people are still here. And I think it just speaks volumes to the exciting and stimulating week we've had. As you know, Lisbon Addiction is all about co-production, and you're very much the people who co-produce the event with us. So a big thank you from all the organisers to the participants of the conference. Before we go to our closing session, the closing of the conference, we always have a final session at Lisbon Addictions. And what we really want to do is have a challenging and thought-provoking session that makes you, when you're on your journey home, or when you're walking around Lisbon, for those of you who are lucky enough to get a little bit of time in our city over the weekend, keeps you thinking. I know you want to probably think about something else, but I think this session is going to stimulate you to really go away from the end of the conference with a little bit of different perspectives on some of the issues that you thought you knew well. The theme of this conference has been all about empowering the workforce. And what we've done in this session, we've split it into 2 different areas. I'm going to start, we've been looking, I think, at national level, at local level, but we're now going to scale up and look at global and European level. And I'm going to invite Dr. Carina Ferreira-Borges from the World Health Organization to talk to us about her work to assess the needs and availability of training programs for professionals in the substance abuse field. Carina holds a PhD in international health. She joined the WHO in 2006. She's a public health specialist who's a real interest in non-communicable diseases. She's acted as the World Health Organization's chief for alcohol, drugs, and prison health in Europe. She's also acted the head of the Office for Prevention and Control of Non-Communicable Diseases. Previously, she's been an addiction counselor. She's a specialist in technical thought, capacity building, and really important for us and some of the interactions we've had is the impressive work she's done to develop public health responses within the prison setting. So, Carina, can I give you the floor, please?
Thank you very much, and it's a pleasure to be here. Thank you for the invitation. And yeah, great. My slides are in. Thank you. Okay, thank you also for bringing me to the last session. As you said, it's always difficult to keep people around, but at the same time, for us who are coming to this session, and at least for me, it helps also to situate the intervention that I'm going to do. And I've been asked to talk about the work of WHO and what we are producing in terms of assessing the needs and availability of training programs for professionals that work in the substance use field. So I've heard along, these last days, a lot of mentions to this particular workforce, and I would like to also share with you a little bit about our insights. My presentation is going to cover four points. First of all, on the global scale of the substance use and the harms, and then, of course, on the availability and sufficiency of the professionals that are working in this area, the gap in training, and also some ideas of what we are doing and initiatives that we are taking forward. So I think, in this conference, we don't need to go very much into detail on the harms, but just to highlight the report that WHO has recently published on that provides, the scale of psychoactive substance use. We cover everything from, alcohol, tobacco, and illicit drugs. And this is a comprehensive report that talks about also, treatment responses, and it provides country-specific data. So as you can see here, when we talk about substance use, we know that the scale is different depending on the drugs that we are talking about, but the important thing is that these are all psychoactive substances, and as such, also they all have an impact in terms of our health, but not only in terms of our health. So if we talk about the health impact and, again, the burden of disease that is associated with both, the consumption of all these drugs, we all know that tobacco is the most harmful substance with many deaths that are taking place because of its use, but we also know that it affects not only the consumers, but those who are also, part of the people that are affected by tobacco consumption. For alcohol, we don't have the same number of deaths, but we have quite a very high number of people dying because of alcohol consumption. And again, I would like to highlight that the harms, again, are not just about to the people that are drinking, but they are also scattered among the society, with violence, injuries being one of the main risk areas for alcohol consumption and in impact in terms of mortality. And then we have drug use that is also responsible for many deaths in the society. But as I said, the impact does not only cannot be only seen in terms of mortality and morbidity, but it can also and should also be seen as the wider social, economic, and security and legal and political implications that it has. So I think that these are all different dimensions that we need to consider, and that I've heard a lot in these presentations here, the different implications that we need to consider when we talk about substance use, and how wide this is in terms of the actions and the interventions that are needed to address the burden it causes to society. So what is, if this is, huge burden that is causing to society, then, how are we doing in terms of availability and in terms of, the sufficiency or, number of professionals available to be able to act in this scale of the problem in terms of substance use professionals? So we did a survey with, as I said, we cover 194 countries. The survey is based on replies from 145 countries, which was quite good. And again, against the backdrop of morbidity and mortality, and then the wider impacts that it has in society, we need to have an available and skilled workforce. So the workforce for treatment of substance use disorders is largely consisting, as you can see here, by psychiatrists, psychologists, so it gives us a little bit, nurses, social workers. We have other professionals that are also working, but it shows that not all the countries have the range of professionals that would create the capacity to support the individuals that are using substances, given the fact that we know that having multidisciplinary teams, it is of most importance for the success of the treatments and the response that we have to have in the countries and also across the different levels of the system whenever someone needs help across, the continuum of services. So the other important point is not only about, the professionals that are working and the scope of the professionals that are working in the field. It is also about, do these professionals have the specialized education and training which would be required to act in the field where they are working. And it's a little bit, as, being, I don't know, doing a heart surgery, for example, without having the knowledge, to do the heart surgery, not just because you are a medical doctor that you would be, of course you can do it in very precise conditions, but we know that we need specialized people to work in specialized fields, and addictions is one of those. So what we see is a discrepancy between availability of professionals and the access to professional development and education. So not only we need to consider, do we have the number of professionals which are needed to treat the people, if we look at the burden that it causes, but do those professionals, are they ready to treat those people? And there is a big discrepancy, and as you will see here, around 10% of the reporting countries do not even have access to any level of education provision in the field of treatment of substance use disorders, meaning that basically there's no training available for people that are working in this field. And we have seen changes, and I think, again, back to, the importance of this conference and the importance of really putting addictions, in the research agenda and in the, in the policy agenda and in the workforce agenda. But we still have work to do, but we have seen that at least in high-income countries, Europe and North America, we do have a growth of specialized training programs for addiction treatment specialists, at different levels, a bachelor, master, and doctoral levels. And this is great to see, but we would like to see this expanding because, again, one of the main barriers to scale up treatment is exactly the fact that we do not have sufficient development, and training opportunities for the health workforce to be able to identify, to be able to diagnose and treat people with substance use disorders. And we know that the gap in terms of the access to treatment and the treatment availability is huge in this area. In whatever, we have more for tobacco. Tobacco really came up very strongly, but we do have a huge gap. And, in most of the countries, in all countries, I would say, the gap is quite substantial and does not meet the needs that are there. So, not only we don't have the services, but we don't have the specialists that are needed there. Again, why is it important? I think I've said a little bit about that. We need to make sure that we include these professionals. They play a very important role in strengthening the efforts that are needed to tackle the harms. And it is important that they are well prepared, again, to be able to do, a quality work and to produce the impacts that are needed to have results. We know, as I mentioned, that there is lack of sufficient training, and this, of course, has an impact in the availability and in the quality of the services that are provided. So some examples of what WHO is doing. Basically, we have been looking a lot to the workforce, and I'll give you some examples of what we have been working on. range of initiatives that look at the workforce, in a broader sense, and also in a more specific sense in terms of education and enhancement of skills, but also in terms of how to support structural changes in the services, because this is also one aspect that is very important, because you may have all the professionals, but if the structure in the system is not ready as well, this will have an impact. So WHO and the European region in particular has, member states have proposed a framework, which is a framework for action on a health and care workforce. And basically this framework has 5 interrelated pillars. As you can see, it covers, a broad range of areas where we need to consider actions and interventions for healthcare workforce. And if you will see here, I have circled, a little bit because I think it fits more into the presentation on the building supply and optimizing the performance. But I would argue that, across all these pillars, there's a lot of work to do for the professionals and the workforce that we want to see in the addiction field. And that covers, both, the investment that is needed in these professionals, again, by having, the opportunities to grow in the career and to grow in the knowledge that they have, but also, again, on the type of measures that we have in place for education and for training, and how we strengthen, the continuity of their growth as professionals, and how we make sure that they also evolve based on the research and the evidence that we have that can be available for them. So again, redefining teams is also very important. So I would just say that this is a very important instrument for the workforce. Another aspect is that we have been very worried about is the mental health of the healthcare workforce. And we've heard here in this conference that, when we look at, there's a kind of a hidden population, which are, the healthcare professionals that are using drugs, but, nobody knows or nobody wants to know, right? And one of the key things that has been put forward was the fact that we do not have, the services that would support. We have a lot of stigma, and, there are several barriers that have been identified that basically hinder the perspective of also supporting, these healthcare professionals that have addiction problems. But on the other hand, we also have the impact of external factors in the mental health and how drugs are used as a coping mechanism to cope with stress. So we are doing a survey, and we want to know how, again, the conditions and, the different types of stress that the healthcare workforce is subject to, is also, leading the way to, poor mental health, but also in particular, and one of the areas that we cover is also substance abuse, although we only considered alcohol, as a first starting point, because how difficult it is for healthcare professionals to talk about their substance use. So it's the starting point, and we're very happy that we're doing this survey. We are also working on, a more broader and complete package of, how would this continuous competence-based learning look like for both the mental health and the areas of substance use care, and we've been working on, the continuum. Of course, you cannot do everything, at the same time, and, pre-service education is extremely important, and this has been the area where we have started, because it is really where we can prepare future professionals, in terms of their role as healthcare providers, and it is something that is done also, in the universities, and with whom we can have, more discussions. So there's, as you see here, 3 types of learning that are closely related. Both the pre-service and in-service training are necessary to secure a competent workforce, and a workforce that continuously improves and that is specialized and that is competent to be able to act in the field of their expertise. So this is the publication. We have done a practical guide for integrating pre-service education for medical and nursing students to provide mental health, neurological, and substance use services. And again, a very important resource that emphasizes, again, the importance of the training, importance of the education, and learning developing the competencies that allow professionals and healthcare professionals to work in a very specific area as addiction, and it is, it takes a competency-based education approach to, situating, again, it's quite complex, and I invite you also to take a look because it situates the attitudes, the knowledge, and the skills in the context of the practice needed for the healthcare services to be provided. More, not only pre-service, but also postgraduate education. We have had recently a meeting, also working with our collaborating centers in China, and this meeting has been the opportunity to really discuss the postgraduate education, the training, the scope, the procedural aspects, and the core competencies of medical doctors, to develop a very specialized workforce in prevention and management of substance disorders for those who are already in the field. And this is work on progress, but we are again, looking at recommendations on how to develop this very specialized workforce. We've also been working together with EUDA, and it has been, really great collaboration. We've been looking at workforce in a very specific setting, many times, the most vulnerable left behind people, and also left behind healthcare professionals. And they are, and we've seen in the pandemic that they were left behind. I mean, including in, essential things like vaccination plans that we were, scaling up in healthcare professionals at, in large, national health systems, but the people in prison, the health workforce in prison was not contemplated. So you see that, again, there is a disconnection also in terms of the workforce that we need to address, and the work, with EUDA has been very important. We put together a course together also with youth, with the Yale School of Medicine and Yale School of Public Health, and this course really provides the opportunity for the workforce that take trainings at their own pace and to conclude, because many times they don't have the time. So this is a kind of resource available that is important for people that have, for in-service training. We have also WHO Academy courses, so this is new. This has been something that we've been developing, for a couple of years, so I'll say new because it took us some time before we got everything together, but now finally we have 2 courses addressing, substance use and substance use disorders, and basically these courses are, again, an important tool that online that can be used by millions of health workers and people around the world, wherever they are. In Europe, we've also been investing on evidence-based and available screening and brief intervention resources. We have a big project called Evid Action, bringing evidence into action, and it covers also the health system's response. It's funded by the EU, and basically one of the areas of the project is about training for alcohol screening and brief interventions, and it is not only of primary health care, but also bringing workplaces and social service setting as key platforms where these kind of services can be provided. And again, when we talk about the health and care workforce, social services and the workplaces need to be very much involved, are part as the ones, working on prison settings. So these are all settings where we have a workforce that is working there that needs also to be taken into consideration. So again, this enables an approach which is not a clinical approach, but is embedded in a public health approach, because this is critical for us to be able to scale up the interventions that are needed and to bridge the gaps between the burden and the needs that are in the field. Finally, just to say also that we've been very much invested in creating resources also for countries where we have, in a way, the need to adapt for culture and also for drinking patterns. So what we have seen is that there's not one fits all approach, and that it is extremely important also to understand the needs at the national level, at the local level, and to be able to adapt and come up with solutions. And this is an online educational course for primary health care workers in Russian language, very much targeted to the patterns that we see in Russian-speaking countries, and that will allow, again, the health workforce to be able to intervene, in addressing alcohol at all levels. So I would like just say to conclude that this is a presentation that I have put together with the support of my colleagues from headquarters and from the regional office, and I would like to thank them also. They should have been here with me. They were not able to come, but I would like to thank them and also thank my team that supported me in putting this together. Thank you very much.
Maybe we just have time for a couple of questions, if there are some. But could I start by just, really impressive set of programs. And this week we've heard, I've been really inspired by some of the initiatives I've heard, some of the programs, but we've got lots of programs in different countries, some WHO, some we've developed in Europe, a lot of US work. But are we doing enough, some great stuff from UNODC, but are we doing enough to put these things together? And are we doing enough to make them applicable to all countries, not just countries which are relatively lucky in terms of the resource levels they have, even where the challenges still remain really great?
Thank you for the question. Yeah, no, we're not doing enough. I mean, those who know me know that I'm very blunt, right? So no, we need to be better in putting everything together. I mean, we have great collaboration. So let me just also say and acknowledge that we have great collaboration, and we've been working hand in hand. I have my colleague here, Anya, from UNODC, and again, we've been exploring with the EUDA on the possibilities of working closer. And I think also this is what is expected from us as agencies, that many times member states would like to see more of this being together. So I think that there are opportunities. So are we doing enough? No. Are there opportunities? There are many opportunities, because there's a lot happening, and we have also the right framework to be able to be acting on that. I think that, again, the importance of this framework and the focus that we are now having in the workforce, having a skilled workforce, can also be an important entry point for the addiction field that we should explore more together. And yeah.
Can I ask, are there any questions from the floor for Katerina? I think it's a big room. People are probably feeling a bit shy. Well, on that, then I'd just say, I was not sure. I was going to ask, are you optimistic or pessimistic? I was thinking, am I optimistic or pessimistic? But after your last comments, I think you've made me more optimistic than pessimistic. So can we give a big hand for... Okay, we're going to change tack a little bit now. Global, increasingly digitally enabled, increasingly dynamic. All these changes in the drug problems and alcohol problems and substance use problems we've been facing have been a common theme running through many of the presentations at this meeting. And we're going to now, I think, turn our focus a little bit to really what I see as future paradigms for drug markets and policies. And we're going to offer you two very different perspectives on this topic. But I think they're looking at the same issue from different directions, and really asking the question, what do we need to do to understand and respond to this more globally joined up highly dynamic and digitally enabled drugs, the drug situation we're seeing in the modern world. So I'd like to invite first Dr. Vanda Felbab-Brown to the stage, please. I was first met Vanda, I think about 15 years ago. I was at a closed policy meeting in the UK in Witton Park, and there were people from all over the world, and I was struck by Vanda's contribution. She really just took over the meeting and really guided us. And when we were talking about who should we have to talk on this topic at this meeting, we thought we were very pleased to that Vanda was available to join us. Vanda is a senior fellow in foreign policy at Brookings Institute and a global expert on international conflict, insurgency, terrorism. Oh, can we change the presentation, please? Okay, guys, we haven't had that many technical problems, but you know, we have to have one or two to. So I'll start again. Vanda is a senior fellow in foreign policy at Brookings Institute and a global expert on international conflict, insurgency, terrorism, illicit economies and drug markets. She has a PhD in political science from MIT. She's written extensively on this topic, and I'll put you to a number of other books she's written, which are just really insightful. She's the director of the Brookings Institute on Non-Armed State Actors. She's co-director on the African Security Initiative. But really what we wanted to come, and why we're really interested in her contribution today, is the lead. She's been lead work on the Brookings work on the fentanyl epidemic. She's done on field work. I was going to say where she's done field work on the topic. The question is, where hasn't she done field work on this topic? It's quite amazing. And if many of you probably have heard it, but if you haven't heard it, her podcast, Fentanyl, the Killing Drugs, is simply brilliant. So I highly recommend you to that if you haven't come across it yet. Vanda, you have the floor.
Well, thank you very much, Paul. It's an enormous pleasure to be here. I'm enormously impressed by the conference, by the quality of presentation, by the work that the European Drug Agency is doing, and by you all, by being here so engaged, so thoughtful throughout the 3 days and even at this late hour. So very many thanks to you. I have learned enormously from all of your contributions. I am also very impressed by the fact that so much of the conference has focused on the public health aspects, on treatment, harm reduction, on responses with people who are using drugs, on the epidemiology, on the public health side, which is sometimes something we struggle with in the United States, where our perspective often comes far more from the law enforcement side, whether that has to do with domestic drug markets and domestic crime markets, or the international supply. And so I will be today guilty of our own faults and focus with you on the supply side of drugs, and particularly on the criminal groups that bring drugs and what effects this can have. What are the potential scenarios that we can imagine? So let me start by making a provocative statement. I strongly believe that the world is going through a synthetic drugs revolution that is sweeping global markets and has profound impacts on both policies toward drugs, on crime markets specifically, as well as even on foreign policy orientations of countries and geostrategic relations. Obviously, synthetic drugs are highly associated with North America, where we are dealing with the most lethal drug epidemic ever in history, where synthetic opioids are killing tens of thousands, even hundreds of thousands of people, even 100,000 people a year. Cumulatively in the US, we lost more people to fentanyl than we have to all soldiers who died in the United States, US soldiers who died since World War II. But this is not unique to the US. Canada is suffering from similar problems, and fentanyl is spreading in Mexico, although that's a much less known story. But North America is not unique in experiencing dramatic changes to drug markets and in experiencing a significant rise in synthetic drugs. In Asia, crystal meth has of course long been established in certain markets. Methamphetamine is one of the primary drugs consumed in China and causing substance use disorders in China. It's of course very long been established farther out in the Asia-Pacific region in Australia and New Zealand. But across Southeast East Asia more broadly, we are seeing a switch from yaba, the long established combination of caffeine and amphetamine, into crystal meth. The markets are hardening, and they are not necessarily hardening because policies are changing. They're hardening because traffickers are increasingly, even in local settings, pushing much harder drugs. I already spoke about the fact that in Australia and New Zealand, meth has long been established as a crucial drug of use, but even there we are seeing significant changes. It is no longer simply Chinese organized crime groups that are bringing meth produced in Myanmar, but increasingly Mexican cartels, Sinaloa Cartel and Cartel Jalisco Nueva Generación, are pushing their super potent and far more lethal meth than we have seen before. In the Middle East, once again, there is a big explosion of Captagon, a story that's well known, that is linked to the Assad regime, but it's just part of the story. A market in the Middle East that has traditionally been supplied by heroin, that has traditionally focused on heroin, is seeing big increases in methamphetamine use. Meth produced mostly in Afghanistan and Iran, meth of not a particularly good quality. But nonetheless, the Mexican cartels are establishing their presence in the Middle East, mostly using the Middle East so far as transshipment points for meth to Australia and New Zealand, to the Asia-Pacific region. But there are certainly many possibilities of how they could partner up with Turkish criminal groups, with Turkish groups that are linked to the Assad regime, to be pushing harder stuff and competing with the Afghan meth. So you might say, okay, but there are these two big outliers then in that story, and that is Europe, where the dominant drugs are, of course, heroin for a very long time and cocaine over the past 2 decades, and Latin America, where it is cocaine, crack cocaine, or other variety of cocaine that are the drugs significantly used. Well, but are they? Even there we are seeing at least some changes, and this is what I will now speak about. I will focus on, are synthetic opioids going to come to Europe? Is meth going to come to Europe on a much larger scale than we have seen beyond the traditional places of, and sources such as Czech meth? But let me just point out that even in Latin America, we are starting to see small emerging supply of fentanyl and initial experimentation by criminal groups with synthetic opioids, even in a market that has no history of opiate use. So let's start with the big question for the afternoon that I am posing to myself. Are Europe and the Asia-Pacific region going to be able to escape synthetic opioids and the lethality that fentanyls and nitazines bring? So what would be the factors to mitigate against their spread? Well, one of the factors I hear from European colleagues is that there is no need to supply fentanyl to Europe, or nitazines, other types of synthetic opioids, because there is so much cocaine coming to Europe, and there is still a lot of heroin available in Europe. So the markets are saturated, so the argument goes by heroin and cocaine. Why would there be any need or interest in developing synthetic opioid markets? Similarly, a counter-argument can be made that there are real cultural differences in drug markets, that fentanyl is highly specific to the United States, Canada, perhaps Mexico, because of unique cultural, historical settings, unique preferences of users. One could also say that users in other parts of the world would be wiser than users in the United States. They see the lethality of fentanyl, they see the lethality of nitazines. Why would there be resorting to using such potent, such dangerous drugs when other drugs are readily available in European markets? And the final argument, a final factor that could mitigate against a wave of synthetic opioids not arriving in Europe, but at least not having the same catastrophic outcomes as it has in North America, is of course that drug policies are very different. Harm reduction approaches, treatment, including methadone, treatment, legal heroin supply are far more established in Europe than in the United States. Until the catastrophe of the fentanyl crisis, many of these policies were deeply taboo, legally prohibited in the United States. And although they are becoming more mainstreamed into policies, they're starting from a baseline of zero and a baseline that criminalized and disapproved of those policies. Very different in Europe, and so the argument can be, even if a big supply of nitazines or fentanyls come in, the response systems are so different that the catastrophic outcomes will be avoided. So let me think with you now through some of the factors that would push against those factors, against the mitigating factors. What are the enabling or overriding factors? So I would go a little bit back in history and alert you all to the 1980s, when cocaine became the drug in the United States, where across the 1980s there's a big explosion of cocaine use in the United States, and where there is no parallel cocaine market in the US. In Europe. And of course, there was no cocaine market in Europe, or essentially no cocaine market in Europe until the mid-late 1990s. And at the time, the explanation often given was that there are these different cultural, psychological factors that drive users in one place to certain use and users in another place to different use. One would hear that US users are part of the US culture. Everyone's on the go, everyone's on the make, it's the to-do society. There is all this pressure to rise, to pull yourself by your bootstraps, and so US wants to do stimulants. Whereas Europe, the argument went, because of different history, because of different culture, was much more into downers. So heroin dominated, was marginal in the US, stimulants were the drug for the US. Well, that might have been the case until the mid-1990s, where all of a sudden, Latin American drug trafficking groups working in cooperation with European drug trafficking groups decide to start pushing a cocaine supply into Europe. And we see, of course, the rise of cocaine use. We see that to be the drug that is increasing. And there was this 15-year gap, 20-year gap, that we really cannot explain on the basis of anything other than idiosyncratic choices of drug trafficking groups. Until one day they wanted to do something else. The market stayed in a certain way. The moment they made a different supply choice, the market changed. And the cultural factors no longer seem to hold. And in fact, now I hear the argument reversed about Europe being so much more into stimulants. So why will fentanyl not arrive in Europe or nitazines take off on a large scale? The argument goes because Europe these days is much more interested in stimulants. And it is the Americans now, with all the challenges the country is going through, that are into downers and fentanyl and opioids. I would also say that what I do not find a credible explanation is that there was not enough supply in the 80s or early 1990s in the Andean region that produces coca. There was plenty. And there were tremendous opportunities for drug traffickers to expand production. They did not lack territory, they did not lack labor supply, they did not face law enforcement challenges to do it. They just did not invest into the development of the market. So are there drug trafficking groups today around that could make the fateful decision of investing in the development of synthetic opioid markets in Europe? Well, the first actor, of course, could be the groups that are most experienced with them right now, the Mexican cartels, the Sinaloa cartel and Cartel Jalisco Nueva Generación. They are the principal producer of fentanyl from Chinese precursors in Mexico, so they buy precursors from China in Mexico, make them into fentanyl, and then smuggle them into the United States. The Mexican cartels are expanding their presence in Europe. They are doing so in various ways. One of them is, of course, they're initiating the development of methamphetamine labs, mostly for their supply route into the Asia-Pacific region. But what is to say that they could not use some of those labs either to produce fentanyls or even initially develop the expansion of meth markets in Europe. Now, what the Mexicans don't have in Europe is wide access to distribution networks, or more precisely, they don't have wide distribution networks. So they would need to rely on other groups to be doing the distribution for them. There are plenty of groups available. Of course, the Italian criminal groups are those with which the Mexicans have the tightest, complex, highly diversified connection. But there has been a strengthening of relations, engagements between the Mexican groups, particularly the Sinaloa cartel, and Turkish groups, and the presence of Albanian and Balkans groups in Latin America is another venue available to them. In fact, we're seeing division of alliances, or alliances is too strong a term, division of relations with Cartel Jalisco Nueva Generación, developing assets, connections, relations, particularly in the Balkans, and the Sinaloa cartel relying on old connections with the Italians and building new ones with Turkish groups. There is another possibility, of course, that it's not going to be the Mexicans who could start pushing fentanyls and synthetic opioids, but that it could be supply out of China. Now, it is supply out of China and India today that is directly bringing finished nitazines directly to retail networks. And those retail networks are often smaller groups. We have seen such groups in the UK, in Scotland, and not connected to large criminal groups as far as we know. And a supply could simply export through this venue without organized crime getting into it. So in other words, Europe today potentially can be in the situation where the United States was between 2012 and 2014. Use at the time after prescription opioids supply was turned down was dominated by heroin coming out of Mexico and brought by Mexican cartels. But Chinese networks, not the powerful ones, not 14K, not the Fujian mafia, none of the triads, but small individual family-based brokers, networks, would start shipping finished fentanyl directly to retailers in the United States. And the Mexican groups were watching it and realizing that their market was being snatched from underneath them. And so they had options. Their option number one choice could have been we just shoot out the retailers that are buying the stuff out of China and not buying our heroin. Now, in Mexico, the groups are extraordinarily violent, have tremendous power, and operate with brazenness and utter impunity. In the United States, because of the strength of law enforcement, they face consequences. So they did not try to shoot out the retailers. Instead, the decision for them was, this stuff, fentanyl, is going to take away the heroin market. We better get into fentanyl. And so around 2014, 2015, we'll start seeing both Sinaloa, particularly the Chapitos branch, and the Jalisco Nueva Generación cartel getting into fentanyl, establishing their connections with China, and developing the supply that would allow them to completely dominate US market in fentanyl. Now, of course, there are very effective, powerful European criminal groups that don't need the Mexican ones. I'm thinking, for example, about Italian mafia groups that have extensive connections with Chinese criminal organizations. A very unknown story is the fact that Chinese money laundering organizations have risen to the top of money laundering worldwide, certainly in the United States and North America, but also in Europe. They dominate money laundering in Italy. They have extensive connections with Italian groups, and many of the money laundering networks are connected to drug smuggling, human smuggling and trafficking, and other criminality. They could easily be a vector by which Italian criminal groups will get their own supply and start producing nitazines or fentanyls at a local scale and pushing them into markets far more robustly. So what about some of the other factors? Users in Europe are more experienced. They had the opportunity to see the devastation in the United States. They will stay away from those drugs, even if those drugs are introduced into supply and become available in retail market. And this argument could be enhanced by the fact that, of course, in Europe, drug testing is far more available than it is in the United States. I wonder, however, how many users do actually test to start with. But apart from that, I would highlight that users in the United States, certainly initially and even today, did not know what they were getting. It was the decision of the retailers and ultimately wholesalers, Mexican cartels, to start mixing fentanyl into everything, including stimulants like cocaine and methamphetamine, as well as, of course, into heroin supply. And we see exactly that same behavior by the Mexican cartels in Mexico, where users traditionally used to getting meth or getting heroin are now finding those drugs highly contaminated or perhaps even dominated by fentanyl. And part of that is, of course, the same old story, that drug trafficking groups like to pay their employees, their proxies, their partners, not in cash, but in drugs. And those that are then paid in drugs need to develop their own retail markets to convert the drugs into cash and liquidity. And finally, regarding the harm reduction and treatment availability in Europe being far more robust than in the United States, and then being able to stop the catastrophe of very many overdose deaths, I absolutely agree that those programs are essential, critical. It is wonderful to see them in the United States expanding from no base, but expanding, growing. It's something that Europe needs to continue to invest in. But I would also point out that Canada and British Columbia specifically, a place in the world that has some of the most established, some of the most well-funded, at least in relative terms, harm reduction programs, is as badly hit as the United States. In fact, some of the Canadian overdose deaths and British Columbian overdose deaths are on par with the worst US hit places. So while treatment and harm reduction are no doubt helping, they can easily become overwhelmed. So in conclusion, let me reflect on one possibility and explore with you whether law enforcement has a chance in Europe and potentially in places like Australia and New Zealand to change the calculus of criminal groups so that they stay away from moving into synthetic opioids, even if they will make into methamphetamine. And by the way, just as a note, meth itself, certainly Mexican meth, has become highly lethal and is a big driver of deaths in the United States, deaths that are rising. So, meth traditionally was high morbidity problems, limited lethality. That is no longer the case with the meth that's entering the markets. So, for example, could law enforcement in Europe crush local retail markets sufficiently, local retail markets that are bringing in nitazines or fentanyls that are distributing them locally to discourage those markets? It's a hard proposition. A decade ago, in between 2006, 2009, law enforcement in Nordic countries essentially succeeded. A fentanyl supply was coming there from the former Soviet Union, Russia space, and a concentrated effort to arrest, dismantle those retail networks did stop, or at least temporarily stop the expansion of fentanyl markets there. Of course, it's more challenging for law enforcement today. The market there was in some ways a niche market. It was supply out of Russia. The groups that were pushing it were small retailers. We never were in a situation where very powerful international organized crime groups would be pushing that stuff. The cat's out of the bags. Traffickers today understand the tremendous advantages that synthetic drugs bring them, and particularly synthetic opioids. So what law enforcement could do a decade ago is not inevitably what law enforcement can do today, because synthetic opioids make smugglers' life much easier. They don't require controls over territory. They don't require a large labor force. That means that production can take place anywhere and does not have to be in countries challenged by war, challenged by poor territorial control. The amount of drugs that need to be moved, smuggled, is a small fraction of the amount of drugs that need to be smuggled in plant-based drugs. And that also means that the amount of people that need to be corrupt is much lesser. So all the inputs go down. The precursors are very cheap, the price profitability is very high, and smuggling, logistic, law enforcement, evasion are enormously simplified. So from a trafficker's perspective, synthetic drugs and synthetic opioids are the way to go. So can law enforcement change their calculus by making it particularly costly for them to move into that area, or at least structure their interest enough so that they bring in synthetic drugs, even fentanyls and even netazines, but not at the level of purity that kills so many people. And I know this is something that the US has been trying to do with its focus on the chapitas. Perhaps there is a glimmer of possibility that the US has been to some extent able to change the calculus. We're seeing less pure fentanyl coming in. That means fewer people are dying. But it's certainly very hard to imagine that we could put the cat back in the bag and that we could get to a situation where plant-based drugs once again dominate the market. So many things to do on law enforcement side, to think through, on the treatment and harm reduction side, to think through. Enormous opportunities and need for all of your insights, information, the work you are all doing in the field, in designing policies, in thinking about the labor force and responses. I am grateful to you all. I am grateful to the European Drug Enforcement, the European Drug Agency. And I look forward to the continuation of the conversation.
Vanda, that was brilliant and challenged us all, I think, to think bigger about this problem. And certainly you put your finger on an issue that many of us are very concerned about at the moment. But what worries me a little bit, we had a meeting on Tuesday, a global meeting, and lots of places in the world we don't have good information. We know synthetic drugs are cheap, they're highly potent, they're highly portable. It's where you get your biggest bangs for bucks. And when I look where the big young populations are now and in the future, it's not in the US, it's not in Europe, it's in Africa, it's in Asia. And I can also see those areas having less strong jurisdictions, and their problems with climate change, their demographic issues, their increasing urbanization. And are we not paying sufficient attention to possibly the drug problem tomorrow while we're dealing with the drug problem today?
Oh, thank you, Paul, for raising that. I wholeheartedly agree. I mean, both Africa, but places like Middle East are just prime to go through real catastrophes in the context where the availability of any kind of intervention, be it law enforcement intervention, prevention, harm reduction, are so limited. a place like Middle East, a place with tremendous trauma as a result of the war. And we are aware of the explosion of Captagon use that is both in places that have been traumatized by war, like Iraq, Lebanon, and Syria, but also in the more affluent and less war-destroyed countries in the Gulf. But I was already noting the rise of methamphetamine markets there. Carina spoke about the lack of medical professionals. Well, last I was in Iraq a year ago, I was trying to get an assessment of how many drug addiction psychiatry specialists there are. And I was told, yeah, like single digits, probably less than 10 people in a country of many million with enormous trauma, enormous psychological, mental predisposition. And of course, a country also like much of Middle East where users are still regarded as criminal, as deficient, with a great deal of trauma, and often the emphasis is on punitive approaches. Africa, another place, we know that the drugs sweeping Africa are ketamine and tramadol. Ketamine is, of course, used in surgery, but the actual supply of ketamine into Africa many, many times surpasses the actual surgical operations in Africa. So I think there is great likelihood that a lot of the ketamine is being diverted into use. But at the same time, we're also seeing real increase in international drug trafficking groups operating in Africa. Sinaloa Cartel, Jalisco, Primero Comando de Capital have bases in places from the DRC, Nigeria, Mali, to Mozambique. And if they behave the way they have done everywhere else in the world, they will start paying their local partners in drugs. And that, again, in the context of youth explosion, lack of jobs, climate change traumas, many of the social and mental pressures that give predisposition toward a drug use that could become a drug abuse, and minimal awareness, minimal preparedness.
Thank you. I'll allow just one question, two questions. Are there any questions from the floor? We have one over here.
Yeah. So thank you for a very inspiring presentation. I'm Lucas Wiesing from EUDA. So you mentioned the crackdown on prescription drugs in the US, and you mentioned many other potential factors. Now, we did not have a crackdown in Europe, but also, in addition, we have a far higher coverage of people who use opiates by opiate substitution, opiate agonist treatment. Moreover, we also see actually the fentanyls coming into the countries with very low coverage. So on average, we have around 50% of European opiate users covered by OMT. But in the countries with the lowest coverage, we see is exactly where fentanyls come in. Do you think that perhaps also this lack of crackdown, and to the contrary, much higher coverage of OAT in Europe as compared to the US, we heard yesterday that in the US it's around 15 to 20%, and we have 50% on average, that is actually a major protecting factor in Europe, and that we might not be so nervous about fentanyls, especially if we manage to crank up the OAT further, above the 50%. Thank you.
So I do definitely believe that that is a protective factor. I guess where I am uncertain is the extent to which it is a protective factor. And here really the debate, I think, becomes intensely about what drives drug markets and to what extent demand factors or supply factors dominate. If I were designing policy, I would certainly want to preserve and enhance and expand the treatment harm reduction options that are there. But I would equally focus on doing my possible to discourage wholesale suppliers from bringing the more dangerous stuff in. So I would not be satisfied with just the medical response or the public health side response is sufficient to stave off a major threat.
Thank you, Vanda. Can I ask everyone to... I've heard a lot at this conference about how our practice, how our research challenges policy, but sometimes policy also challenges our research and practice. And I want now to, I'm very pleased to invite our last speaker up to the stage, who's going to give us a different lens on this problem from a really pragmatic and I think practical experience of a policymaker who's had to deal with these issues in a large European urban environment. So it's a great pleasure for Lisbon's Addictions to invite Femke Halsema. I hope I've got that nearly right. The stage. Femke is a criminologist. She studied at Utrecht University. She's worked extensively in public administration, and she's got a reputation for translating complex practical issues into practical and actionable solutions across a range of difficult policy areas. She's also a political author, filmmaker, and business leader. She's got a fascinating political memoir, which is, I'm going to pronounce this one, it's Plush, is that right? And that, I think I'm right here, that's the velvet material that it lines the seats in the political buildings. Am I correct? I thought that's it. Really pleased to have you here. In 2018, she's appointed Mayor of Amsterdam, and it's in that role that she's speaking to us here today. And she's applied her diverse skill set to developing a pragmatic solution to the problems faced by this big, modern, urban European city. And today she's going to tell us all about Amsterdam's quest for a sensible drug policy. And in doing so, I think she's going to be looking at some of the same issues that Vanda has explored, but from a different angle, through a different lens. But please, Femke, can you take the stage?
Well, thank you so very much. And yes, Plush, the seeds of the powerful are made of it. Ladies and gentlemen, good afternoon, and I hope I can end this beautiful conference and so interesting conference maybe on a more hopeful note. Ladies and gentlemen, it's a privilege to be among so many health experts because drug use is first and foremost, as was also demonstrated in the former speech, a health issue. And I was wondering if there are also mental health experts in the room this afternoon. Are there? Yes, because I have a question. Because I think that the definition of insanity is doing the same thing over and over again while expecting different results. You understand? It's more of a rhetorical question. I think that is what we're doing with the war on drugs. I will get back to this question later. First of all, I would like to extend my heartfelt thanks to the EUDA. I don't want to say the European Drug Enforcement Agency, although I understand how the mistake can come along, the Portuguese Institute of Addictive Behaviors and Dependencies, and all the other organizations that helped organizing this pivotal event. Your efforts provide an invaluable forum for networking and high-quality scientific debate across the addictions field. In recent years, I have witnessed the devastating impact of the ongoing battle against drug trafficking. In Amsterdam, youngsters are being lured into criminality, and we have seen daylight killings of a crown witness in a huge drug court case, his lawyer, and the famous Dutch journalist Peter R. de Vries. And despite significant efforts and resources, our current strategies have not succeeded in reducing the availability of drugs or the power of criminal networks. The Netherlands remain a major hub for cocaine trafficking, with record seizures that do not seem to impact the street availability of cocaine, nor the street prices or the associated violence. Violence is even getting worse. Every week in Amsterdam, the police finds several apartments being used for drug trafficking. In addition to cocaine and other drugs, they find big stashes of cash money, guns, and ammunition. More often than not, these apartments are right next to children playgrounds and schools. And the police are doing wonderful work. They work hard and they have excellent intelligence. But our government, our national government, is letting them fight a battle they cannot win. Our strategies have remained largely unchanged for decades, while the dynamics of drugs use and trafficking have evolved. It's clear that a new approach is needed, one that is grounded in evidence and public health rather than in repressive tactics. In Amsterdam, we have adopted progressive policies in the past. Our approach to heroin addiction, you probably heard about it in the 1980s, which included methadone programs and harm reduction programs, significantly reduced drug-related crimes and health issues. The combination of health and social responses with targeted approaches to nuisance and criminality proved successful. Teams composed of police officers and social workers closely examined habitual offenders and asking them, "What do you need? We are really going to try to help you, but if you don't cooperate, you will end up in jail." These measures demonstrated that a pragmatic approach focusing on public health rather than on the ideological approach of criminalization can yield positive results. However, we cannot rest on our laurels. The challenges we face today are more complex than ever. Synthetic drugs like MDMA have become increasingly popular, and the illicit market continues to thrive. The recent EUDA report, it was published, I think, in 2023, provides crucial insights into the drug situation in the Netherlands and in Amsterdam and the urgent need to change the discourse. First, the Netherlands remain a significant hub for cocaine trafficking in Europe, and especially Amsterdam. In 2021, the country accounted for 72 tons of cocaine seized, highlighting its central role in the European cocaine market. And despite these seizures, as I already mentioned, cocaine availability on the streets remain high. Second, the Netherlands is a major producer of synthetic drugs, including MDMA and methamphetamines, if I pronounce it well. In 2021, the country dismantled numerous large-scale production facilities, underscoring its pivotal role in the synthetic drug market. Third, the Netherlands is piloting a model for a closed cannabis supply chain for coffee shops. This initiative aims to reduce illegal trade and improve product safety by regulating the entire supply chain from production to sale. Although, for political reasons, I think it will not end well, this pilot, unfortunately. These 3 points, highlight the complexities and challenges of drug policy in the Netherlands and underscore the need for new approaches. Because one thing is clear, I may say, after more than 50 years of war on drugs. Simply prohibiting and enforcing, no matter how strict, does not provide a lasting solution. And secondly, it undermines providing generous and targeted care for people who are homeless or suffer from mental health problems. They fall through the cracks and get even more marginalized than they are today. We need all the expertise available at the EUDA to work with the right data on users, and this will help us to understand the full scope of drug use and its impact. allowing us to tailor our policies more effectively. It is also encouraging to see how the EUDA has evolved to support more progressive policies. In the past 5 to 10 years, we have witnessed a significant shift in its approach. Once hesitant to endorse measures such as drug consumption rooms and drug checking, it now champions these initiatives as essential tools. And this shows EUDA's commitment to evidence-based practices. And it's particularly heartening to see the EUDA's new role, which extends beyond data collection and health advisories to include policy and advice on health and security. And it also recognizes the importance of local level engagement and cooperation with cities. And this is promising. In recent years, we can see a cross-border coalition of health professionals, scientists, NGOs, officials, and politicians advocating sensible, evidence-based drug policies. And at the same time, we must also acknowledge ultra-conservative forces in our societies, worldwide and in Europe and in the Netherlands, and politics have also gained support. And they support the war on drugs. They talk about being tough on crime, longer and harsher sentencing, and cutting the budgets of crime prevention and public health programs. Just the last week, we saw cutting of health prevention programs in the Netherlands introduced by the new right-wing government. Ladies and gentlemen, this is why we have to strengthen a coalition for sensible drug policies. We have to work harder to inform our citizens and our governments, and we have to speak out. We have to speak out for our police, for our prosecutors, and for our judges, because otherwise we are letting them fight a battle they cannot win. And we have to speak out for public health and the safety of our cities, because the organized drug crime is poisoning our neighborhoods, not only with drugs, but even more with violence and dirty money. And we have to speak out for a new generation of youngsters. They are the future of our cities. Only if they won't be caught up as foot soldiers in a senseless international war on drugs. And we must move beyond the outdated, ineffective approaches and embrace a more humane and rational approach. This brings me to one of the core messages from the Dealing with Drugs conference that the city of Amsterdam organized in January of this year. What we advocated was the need for controlled regulation of the international drug markets. These are probably people from the Netherlands too. This isn't about promoting drug use or being naive about the dangers of drug use and drug abuse. It's not being naive about the criminals creating addiction and dependency. But it is necessary to rethink the criminal networks and to dismantle them because they thrive under prohibition. By regulating drugs, and I know it's going to cost many years. It's not something you introduce just for the coming years and see how it ends. It will take us probably tens of years before we have a worldwide discussion and the first experiments. But it's no reason to wait. By regulating drugs, we might ensure a safer and controlled environment for users, reduce health risks, and redirect law enforcement resources to more severe crimes. For instance, in Amsterdam, at this moment, almost 80% of law enforcement is directed towards drug crimes and not towards sexual crimes or crimes in the houses. So it's all directed towards drug crimes. As part of our efforts, we are working in Amsterdam on building a coalition of cities willing to experiment with controlled regulation. And this coalition, we hope, will share knowledge, experiences, and best practices, creating a united front to address drug-related issues more effectively. I am specifically keen on experimenting with a controlled regulation, of course, of cannabis, but also of MDMA, because of its relatively low toxicity and controllable nature of problematic use. Studies have shown that MDMA, when used in a regulated environment, poses fewer health risks compared to alcohol, smoking, and gambling. Cities are the first to experience the negative effects when drug policy fails. Therefore, they have been and will continue the breeding grounds for new drug policy practices and the catalysts for change. But we also need your scientific brainpower and your strength to help us to how we can modernize drug policies. The work you do matters immensely. Your research, your commitment to understanding and solving complex issues related to drug use, and your dedication to public health are the cornerstones of a safer, healthier future. Let's continue to support each other, to share knowledge, and strive for policies that truly make a difference. Instead of relying on tough slogans, let's focus on evidence-based solutions. And instead of fruitless repression only making criminals richer, let's pursue sensible harm reduction. Instead of fear, let us lead with compassion. Thank you. And may I just add, before I forgot, we wrote a manifesto last year in the Amsterdam conference, and it's still open for you to sign. So please, it is already supported worldwide, but we really need a broad audience and many supporters. So you can see it on the link. Well, it is, I think, dealingwithdrugs.com.
Thank you. That's certainly offered some, I think, quite compelling and, dare I say, controversial views to our audience.
Well,
just starting
I'm from Amsterdam.
And Amsterdam, a wonderful city. Do you think there's something about cities that, lots in the EUDA, we deal with countries and national policies, but increasingly, do you think cities provide a laboratory, if you like, for some policy experimentation and development? And if so, how do you think we might encourage, how might we use that in a perspective like we have in Europe to see how different models and different policy approaches can play out within different cities in Europe or worldwide?
Well, I think traditionally cities are very often the places where young and progressive people come together, and they are also counterbalancing their conservative climates. That's probably one reason why cities can play a key part. But we also, the most horrible effects of drug abuse and of international drug trafficking are seen in the cities. We were discussing it this morning. My main worry at the moment is not the drug use, but is young people getting into drug trafficking. That is in Amsterdam the biggest problem at the moment. Many very vulnerable young people, they are not using drugs, or they are using it recreational but not problematic, but they are into drug trafficking. They are used by international, immoral, heavy criminals to spread and diversify the markets, and they end in prison, they end dead, or they end with their mothers on the couch and their mothers crying, and that's the best option we have.
Okay, and I think really that idea about the harm derived from the drug market is something that unites both your presentation and Vanda's presentation, and just looking at this really complicated issue from different lenses and different perspectives and at different levels, I guess. Is there any, we're getting very near our time, I could take one question.
Can I make one more remark, just because I was very intrigued by the beautiful worldwide sketch the former speaker gave. It's very interesting. But as that is a scientific approach, and I'm a governor, and what's missing is the answer to the question, how come? How come fentanyl is pushed onto the markets worldwide, distributed amongst vulnerable people? And the answer is very simple, because it's the business model of criminals who really thrive on dependency and addiction. So this is where we have to start finding the answers. And I am not naive in thinking that it will be easy, but we do have to find answers in regulation, in controlling the markets.
Okay, we are getting, I've told the chairs all week to keep time, and they've all kept time, so I need to be a good chair, but I am going to allow, I can just allow one question.
Thank you. Hi, Lynn Jeffries. I work for the European Network of People Who Use Drugs. And this ties into the last person's presentation and yours as well, in terms of what we're seeing in North America, synthetic opiates, what we're talking about now, regulation in Europe, given that the preliminary findings on safe supply and the effectiveness of that in addressing what you've been discussing. What do you think about having those conversations now, a safe supply policy in Europe, before we're 8 years down the road like British Columbia is, in terms of an overdose crisis? Just your thoughts on safe supply.
Well, I do agree that it is necessary and urgent to start a discussion on safe supply, and also about on controlling the markets, because not only are the people who use drugs in danger, but for instance, in my city, youngsters who do not use drugs but traffic them are in danger, but our complete local economy is in danger. It undermines the legal economy, because the gains in cocaine traffic are huge, and they are becoming more huge. So yes, we need to talk about safe supplies, and not only because we have a problem in Europe. There's also a problem in the Middle Americas and in African countries. There's a problem with the farmers being exploited. There's a problem with dumping of waste in the poorest parts of the world. So to me, it's unimaginable. If you see the numbers the lady from WHO presented, if you compare it to alcohol and tobacco, the problem of drugs in terms of worldwide prevalence and social and societal effects are much smaller. Why can't we solve the problem by just organizing and controlling, starting to control and organize the markets, and having a rational and not an emotional and not a moral but a pragmatical discussion about it?
Thank you.
Could you join with me in thanking our last speaker of Lisbon Addictions? Oh. And before I leave the stage, I just want to give one last thanks, not only to all our free speakers, but also to you, the audience, who on a Friday in Lisbon, after a busy week, you're still here and you're still engaged. So can we just thank ourselves and our speakers. Personally, it's been a great conference. Great pleasure now to hand over for our closing ceremony.
Thank you very much, Paul, and hello again, everyone. Good afternoon. So we really are at the end of our time together, at least our face-to-face time together. And I just have two things before I invite Manuel Cardoso on stage for the closing remarks. First of all, I'd like to draw your attention to the conference assessment questionnaire that you'll be getting in your email in the next couple of days. Please do give us feedback on all the different aspects of the conference so that we can really make further efforts to shape it to your needs, the next one to your needs. And the second thing we have is something that we're really excited to share with you, which is a video of some of the highlights of the last 3 days that you've all made so special and so inspiring for all of us. So please do play that video now. Thank you very much. Sorry, we seem to have a problem here, but I'm sure we will resolve it. If not, perhaps we can show that later. And I'd really then like to, perhaps we work on showing the video, and you think? So yes, Manuel, it's a great pleasure to introduce you. Manuel is member of the Executive Board of the Institute on Addictive Behaviors and Dependencies. He's been Secretary General of the National Alcohol and Health Forum since 2008, and he's one of our precious co-chairs of the conference program committee. The other one was Paul, who was just running the last session. So Manuel, you have the floor, and welcome. And perhaps we can just play the video when it's available, or what do you want? How do you want to do that? Yeah?
Well, maybe in the end. If
Yeah,
possible.
we'll do that on then. If it's possible, we'll play the video in the end. So Manuel, please go ahead.
Okay. Hello, everyone. Good afternoon. It's amazing the number of you that are with us. I promise that I don't keep too much time from you. I hope we can see some numbers here, but saying that more than 2,000 delegates from more than 100 countries is coming, and more than 1,300 abstracts were submitted. And it's amazing, but more than 80% were classified with a high quality classification. Just 22 were rejected due to the scientific committee's low ranking. I think that's great. Dear participants, dear colleagues, let me express my sincere gratitude to those who submitted abstracts, and in particular, to those who have achieved such a high level of quality. Thank you all for being here, for sharing your work and to allowing policymakers to have more information and evidence for their decisions. I would like to acknowledge the work of the scientific committee responsible for the review of the overwhelming number of high-quality abstracts submitted, more than 1,500 to be true, counting also the late-breaking abstracts. Thanks to those who delivered presentation, in particular the keynote speaker and all the chairs. And I wish to thank you all for having joined us in the fifth European Conference on Addictive Behaviors and Dependencies. Your dynamic and committed participation has made this conference once again a successful event, and I am grateful to each and every one of you. I am really happy and deeply grateful that your enthusiastic participation on this comprehensive and multidisciplinary event confirms Lisbon Addiction as a unique opportunity for networking and for fruitful contacts among researchers, practitioners, and policy experts. I hope you have enjoyed as much I did the presentations, the interactions, and the knowledge on addictions that has been showcased. I hope also your only complaint was deciding between so many great options, finding out where to go and which presentation to attend. You had plenty of options and the flexibility to choose what interested you most. Dear colleagues, we are closing the fifth edition of Lisbon Addiction after beginning in 2015. It's now time to take stock of these 5 addictions in numbers. We have participants since 2015, more than 600, then more than 1,200, 1,300, more than 1,800, and this year, more than 2,200 participants. And looking about countries you came from, we had 58, 70, 80, 85, and this year, 103. And looking about the abstracts, 366, more than 700, more than 800, more than 9, and this year, 1,361. It's a fantastic evolution. But this is a conference on addictive behaviors and dependencies. And although the number of abstracts has increased with each addiction, the proportion of research related to drugs is, on average, more than 60%. And those related with alcohol were only 10, 12%. And related with tobacco, 3%. And other addictive behaviors around 7%. However, you heard Carina and the status report. That report from WHO tell us that in 2019, tobacco was responsible for 8 million deaths. Alcohol, 2.6 million deaths. And illicit psychoactive substances for 0.6 million. So, policymakers need more scientific evidence, more research to support more effective decisions to reduce these consumption-related deaths. Addictions and dependencies, whether related to alcohol, drugs, tobacco, or gambling, should be considered an health issue, and the force should be on implementing measures that tackle public health and safety concerns, bringing social benefits to everyone. Also, addiction policies must be strongly grounded on human rights principles to secure that actions and resources are effectively designed to protect individuals and thus promoting health and welfare of humankind. Dear colleagues, you were the mayor of Amsterdam. So allow me to conduct a research to the health impact of legalizing or regulating the use of all drugs and not cannabis. Yes, I repeat, I am challenging you to conduct research on the health impact of legalizing, regulating the use of all drugs, not just cannabis. Provide decision makers and politicians for more information about the health gains and losses of such decisions. They need evidence. So, dear friends, the time is come to thank the organizations that jointly make Lisbon Addictions possible. ICAD, the Institute on Addictive Behaviors and Dependencies, EUDA, the European Union Drug Agency, the journal Addiction Society for the Study of Addiction, and ISAGE, the International Society of Addictions Journal. Allow me to call to the stage João Golão from ICAD, please, Alexis Gusdil from the UDA, Sarah Welsh from the Addictions SSA and the Addiction Journal, and Casey Calver from ISAGE. And I have something to acknowledge. Please. And Casey? I have something to acknowledge your commitment with Lisbon Addictions. So, first organizer, please. Okay. Another one. And the second one, thank you. Sorry. Thank you. Ok. Tu mandas. Agora. Não posso falar. Please. stay with me because we are also grateful to the 7 co-producers which made an amazing contribution to enriching the conference program. I also call their representatives to the stage. So, Jorgen Bramnes from the European Federation of Addiction Society. Jorgen? Okay. Emma Day from the International Network on Hepatitis and Substance Users. Thank you. Bo Kilmer from the International Society for the Study of Drugs Policy. Bo? Okay. Natalie, thank you. Não, deixa-me dizer os nomes primeiro. Sarah is already with us, and from the Society for the Study of Addiction, and Zsolt Dimitrovic from the International Society for the Study of Behavioral Addiction. Zsolt? Okay, thanks. Ina Koning from the European Society of Preventing Research. Oh, God. And Sylvia Matrai from the WAVE project. Did you come? And now, yeah. Okay. Yeah. Producer, yeah. So, you have 2. Yeah. Okay, ladies first. Okay. Thank you all. And now, yes, you can take a picture. Can you come here for the picture, please? Yeah. So, thank you all, organizers and co-producers, that give us the possibility to have this conference. Thank you. Thank you, thank you. So it's difficult to manage this. So many. Okay. So, I wish to thank also to the European Commission, the World Health Organization, the United Nations Office on Drug and Crime, the Pompidou Group, and the Inter-American Drug Abuse Control Commission for their support. And this year, Christophe Breckler gave us a funny perspective of the conference. We hope you have enjoyed it. Thank you, Christophe. So a special thank to Camurus for their sponsorship, the Lisbon Congress Center's representatives and the local organizer, Agência Abreu, and the on-site events, as well as all the staff who gave support in the conference rooms. Thank you. So, last but not least, I must to thank all those who have worked behind the scenes. And in a special way, I would like to thank the program committee and in particular EUDA colleagues that worked really hard to put together the impressive conference program, and to the organizing committee for the fantastic job on the logistics of the event, the communication, corporate image, website, and app of our conference. Allow me to express my special gratitude and sincere thanks to Paul Griffiths, who shared the program committee with me. Please, Paul, can you join? And I want to call also the program, the organizing committee, Sofia Santos and Claudia Balzac for overseeing the conference organization. Yeah. No. This is yours.
Thank you.
It's nice.
It's really nice.
Yeah. And share. Oh, thank you. Thank you. So, please stay with me because we have to thank
Another photo.
yeah. So please stay. So, because now we have the organizing committee, and I ask Alexandra Bo, Angela Antunes, Bibi Sedat, Carla Cachola, Elsa Maia, Filipa Cunha, Irene Conduto, Catherine Robertson, Oscar Duarte, Sandra Lobo, Sandra Vilar, Silke Witt e Sónia Ferreira. Já tem? Não tens? Não tens? Ok. Já tem. Ok. Força. So, do you have the picture already? Yeah, okay. Thank you so much. Okay, ladies and gentlemen, I'm close this conference with a sense of accomplishment. Over the last 3 days, we emphasized the crucial role of science and research in providing timely and accurate information to guide decision makers in shaping addictions policy. I trust that you all enjoyed Lisbon Addiction as me. However, this time, considering what you have heard from João, Alexis, and Paul, I'm not in a position to announce the next conference. but I invite you to keep in touch, to keep an eye on our website and social network, and to block the 3rd week of October 2026 in your agendas. I hope this conference has fulfilled your expectation and wish to those staying in Lisbon a very pleasant journey and a safe travel back home to all of you. Thank you again, and please be happy. I declare the 5th European Conference on Addictive Behavior and Dependencies We have the film of the pictures, but I declare the conference closed. Thank you so much.